The next thing that we're going to look at is the greater palatine nerve block. Now, what is greater palatine nerve? As we have discussed before, greater palatine nerve is a branch. Greater palatine nerve is a branch of the maxillary nerve that is coming through the pterygopalatine fossa. It enters the medial wall of the pterygopalatine fossa, descends into the palate through the descending palatine canal. We're going to discuss this descending palatine canal again in detail when we look at the maxillary block through the greater palatine approach. However, once it descends through the descending palatine canal, it exits the canal through the greater palatine foramen. Now, this greater palatine foramen is located in the horizontal process of the palatine bone. We can appreciate here there is a suture that is running here. This is a maxilla and this is a horizontal plate of palatine bone. So, the foramen is located in the horizontal process of the palatine bone. Once the nerve exits from here, it branches out to give nerve supply to the palatal mucoperiosteum. From the third molar till the region of canine, the whole area is supplied by the greater palatine nerve, medially till the midline. Till the midline, medially, anteriorly till the canine and also posteriorly till the third molar, this whole area of the palatal mucosa derives its nerve supply from the greater palatine foramen. Now, when is this block indicated? Whenever you are doing an extraction or any minor surgical procedure on the teeth where you need palatal anesthesia, that is when you have to give greater palatine nerve block. Now, what are the landmarks that are used to identify the greater palatine nerve? We have to first identify the vertical alveolar. The first landmark is a second molar tooth. In the distal half of the second molar, and third molar region, we palpate the vertical alveolar shelf and the horizontal alveolar shelf. The corner of this vertical and horizontal alveolar shelves, when we move our finger posteriorly in the area of distal half of the second molar, we will feel a small dip. That is a point where the foramen is located. So, you can see this is the socket of the second molar, the distal half of second molar, this is a vertical alveolar shelf, this is a horizontal alveolar shelf. In that corner lies the greater palatine foramen. So, to run through again, distal half of second molar, the first landmark, the vertical alveolar shelf, second landmark, the third landmark is the horizontal shelf of the palate, and at the junction of the horizontal and the vertical shelves of the palate, we have in the region of distal half of second molar, we have the greater palatine foramen. So, having known the landmarks, how will we anesthetize the nerve? Always the block, the needle is passed from the opposite side so that we don't tear the mucosa. So, once we go from the opposite side, having located the dip, we go from the opposite side and then we hit the bone, and once we hit the bone in the area of dip which you have palpated with your finger. So, first what are we doing? We are palpating and locating the greater palatine foramen using the foresaid landmarks. And once you palpate in this region, you will feel a small dip in the mucosa. So, you can use your cotton bud or a Q-tip, place pressure on it so that we localize that area of the foramen. Take the needle from the opposite side and then enter the mucosa from the opposite side, hit the bone, aspirate and inject. Now, what is the volume that you will use? We use no more than 0.2 cc, that is 0.2 ml, that is deposited on the palatal side for the greater palatine foramen. Often, greater palatine block is extremely painful for the patient because the mucosa of the palate is firmly adherent to the maxilla. So, to avoid pain, what we do is we apply pressure with the Q-tip in the region of foramen, and pressure, because of gate control theory, reaches the brain faster compared to the pain sensation. That is why patient does not feel extreme degrees of pain when we are trying to apply the greater palatine block. So, once you have administered the block, greater palatine starts acting very fast because of the proximity of deposition to the nerve, and we can see that the whole of the palatal mucosa of one side gets anesthetized with this technique. So, we have discussed the landmarks, the greater palatine foramina at the junction of horizontal and vertical shelves of the palate, and this foramen is located between second and third molar. So, the location is between the region of second and third molar at the junction of the vertical and the horizontal alveolar shelves. Area of insertion is into the mucoperiosteum from the opposite side. After we have palpated this, you can use Q-tip, and once you have felt the dip in the bone, use your left hand. If you are a right-hander, use your left hand, feel the dip, identify the foramen in the area, use a Q-tip, apply pressure, then go from the opposite side, take the needle, insert, hit the bone and deposit 0.2 cc, and then the greater palatine nerve is blocked. So, what are the areas anesthetized? As we have discussed, the whole of the area from the first premolar till the third molar, the palatal mucoperiosteum of this area is completely anesthetized, and the patient feels heaviness and numbness in that area. That is what the patient feels subjectively, and you can elicit it with a Moon's probe by applying blunt force in any of these areas. So, that is greater palatine nerve block. So, this is what happens. Once you have deposited your local anesthetic, you will see that there is blanching, and the blanching happens because of two reasons. One, because of the subperiosteal deposition wherein the periosteum is firmly adherent. Second, because of vasoconstrictor that is present in the local anesthetic agent. Both of them contribute to the blanching that you see when you do a greater palatine nerve block. Having said this and known how to deposit the local anesthetic for a GP block, what are the complications? The most common complication is the quantum of pain. You inject for a PSA because the tissue is loose, the volume of the anesthetic gets diffused, so it is not as painful. However, because this is firmly adherent to the underlying bone, this can be an extremely painful injection. And how do you prevent this? As discussed, we apply pressure. As we are showing here. We apply pressure with a Q-tip or a cotton bud so that the pressure sensation is perceived by the brain, because it is conducted at a faster rate compared to the injection or deposition of the solution as described by the gate control theory. That is how we avoid extreme degrees of pain. The other way that we can avoid pain is by using a local anesthetic spray or a gel, local anesthetic gel, which diffuses through the mucosa and then it anesthetizes the nerve, surface nerve endings, so that we can deposit and give the block. So, that is greater palatine nerve block. The next thing that we are going to see is the nasopalatine nerve. The nasopalatine nerve is again a branch of the maxillary nerve that is starting in the pterygopalatine fossa, as we see in this area. It travels from the pterygopalatine fossa, it goes medially. Medially is towards the midline. So, it pierces the perpendicular plate of palatine bone, which forms the medial wall of the pterygopalatine fossa through the spinopalatine foramen. What is a foramen? Spinopalatine foramen, which is present on the medial wall of the pterygopalatine fossa. If you remember, we have done this before. That is the pterygopalatine fossa. That is a medial wall that you are seeing on the medial side. That is formed by the perpendicular plate of palatine bone. It has a small foramen in it, that is the spinopalatine foramen, and it is through the spinopalatine foramen that the spinopalatine nerve enters the nasal cavity, travels in the floor of the nasal cavity as spinopalatine nerve, then enters the nasopalatine canal, which is a canal in the anterior palate, and comes out onto the surface through the nasopalatine foramen. It comes out through the nasopalatine foramen. So, this is the complete course of the nasopalatine nerve from its origin in the pterygopalatine fossa, in the lateral wall of the nose, and its exit into the palate. Once it enters the palate through the nasopalatine foramen, it divides into multiple branches and then supplies the mucoperiosteum of the palate from the canine to the contralateral canine. So, if we have to do any procedure on the palatal aspect of the anterior teeth, then we have to give a nasopalatine nerve block. Now, what are the landmarks that we have to identify the nasopalatine canal? We have to identify the incisive papilla. The incisive papilla, which is a small elevation that is present on the palatal aspect of the central incisors. So, that is where the incisive papilla is. So, we identify the incisive papilla, that is a soft tissue overlying the nasopalatine canal. So, you inject directly into that area to deposit your local anesthetic. Again, to say the palatal mucosa in this area is extremely firmly adherent to the bone. So, nasopalatine block is one of the most painful blocks that we will ever give in the maxilla. So, how do we avoid pain? Again, as I mentioned, you apply pressure with the Q-tip, or you can use local anesthetic gel or spray so that we avoid the pain that we encounter when we are giving the nasopalatine block. So, to rehash again, our landmarks are the two central incisors, the incisive papilla, which is a soft tissue that is covering the nasopalatine canal right behind the two central incisors. Now, once we have identified the incisive papilla, how can we block this nerve that is exiting the nasopalatine canal? There are two ways to block the nerve. One is single point insertion, wherein we identify the incisive papilla, go from the opposite side of the mouth, insert the needle into the incisive papilla and directly deposit the local anesthetic solution. This is the single point of insertion of the needle, and the problem with this technique is the pain that is encountered during the insertion, because of which sometimes we may not be able to deposit the complete 0.2 cc, and often the LA spills into the mouth instead of entering the tissues. So, that is a disadvantage of single point of insertion. The other technique of insertion, the other method of nasopalatine nerve block includes 3-point insertion. Now, what do we do in this? First, we give local infiltration in the region of the central incisors. How is the local infiltration given? We take the needle parallel to the long axis of the tooth that we have to anesthetize, reach approximately the root level, aspirate and inject. So, local anesthetic technique does not differ, or the local infiltration technique does not differ for any tooth in any area. All we do is just go parallel to the long axis of the tooth, aspirate and inject. Now, the same thing we are going to do here in this nasopalatine nerve block. The first point of insertion is the long axis of the tooth, the central incisor. You go and there you infiltrate so that the labial mucosa is numb and the interdental papilla is numb. Then take out the needle, insert the needle into the labial interdental papilla between the two central incisors. So, what is the second point of insertion? Labial interdental papilla between the two central incisors. So, when you take the needle, insert it and go a little more deeper, we come onto the palatal site at the palatal interdental papilla of the central incisors. There you aspirate and inject. So, what does it do? It anesthetizes the region of the nasopalatine foramen. Then retrieve the needle, go back in like how we have done the single point insertion. Now go and insert the needle at an angle of 45 degrees into the palatal aspect. Now the pain is not going to be there because we have already infiltrated this area. So once you can easily reach the nasopalatine canal, aspirate and deposit the local anesthetic. So this is 3-point insertion technique. Whereas the first one we saw wherein we are directly inserting into the incisive papilla, that is a single point insertion technique. So once you have done this, then what is the amount of local that we deposit? We deposit 0.2 cc. So for all kinds of palatal anesthesia techniques, we use 0.2 cc and not more than that. It is not needed to use anything more than that. And what is the needle that we use? We use a 25 gauge needle, and then the length of the needle is 25 millimeters. That is the needle that we use. Once you have done this, then wait for 5 minutes to see if the area is anesthetized. Now, where is the area of anesthesia? We will see that the palatal mucoperiosteum from the canine to the opposite canine are completely anesthetized during this process. So, that is nasopalatine block. Now, what are the complications of nasopalatine block? The most common complication of nasopalatine block is the extreme degrees of pain, and this can be avoided by use of pressure with the Q-tip as demonstrated here, or you can use a topical spray or topical lignocaine jelly, which will diffuse and give topical anesthesia so that the pain of injection can be avoided. So, that is nasopalatine block. Now, having discussed that, the next thing that we are going to look at is how do we block the complete maxillary nerve. How do we block the complete maxillary nerve? How do we block the complete maxillary nerve? Now, we do know that the maxillary nerve, once it exits the foramen rotundum, it is in the pterygopalatine fossa. So, this is the pterygopalatine fossa that we are seeing. So, if we deposit our local in the pterygopalatine fossa, we will be anesthetizing all the branches of the maxillary nerve, including the divisions that are passing through the ganglion in terms of orbital, pharyngeal, palatal and the nasal branches. So, depositing the local anesthetic in the pterygopalatine fossa, we are going to block all of these nerves. Now, how do you reach the pterygopalatine fossa? There are two approaches to reach. The first one is the high tuberosity approach. The high tuberosity approach is very similar. It is a buccal approach to reach the pterygopalatine fossa. And how do you do this? This is very similar to how we give a posterior superior alveolar nerve block. We go at an angle of 45 degrees to the second molar. We go at an angle of 45 degrees to the second molar. So, our landmarks are the second molar, the tuberosity and also the mucobuccal fold in the region of the second molar. So, what are the three landmarks? We have the second molar, the tuberosity and the mucobuccal fold. So, you identify these three. Now, take your needle. What needle do we use? 25 or 27 gauge needle, which is 25 millimeters in length. Once you have taken the needle, then you insert the needle into the height of the mucobuccal fold and then advance it so that you reach the posterior surface of the maxilla. More than 2/3 of the needle goes in. There we had less than 2/3 of the needle that goes in because we just had to reach the posterior surface. Here we go ahead by another 5 to 7 millimeters so that we reach the pterygopalatine fossa. Once you have reached this area, there is no bony landmark. There is no bony landmark. We do not hit any bony landmark once we have inserted in the right place. And once you have reached more than 2/3 of the needle is gone in, then we aspirate and then we deposit the local anesthetic solution. The amount of solution that we need is 1.2 to 1.5 ml that is deposited in this area, and that is when all the branches of the maxillary nerve get anesthetized. So, this is high tuberosity approach for maxillary nerve block. So, to look at it again, what are the landmarks? Mucobuccal fold of the maxillary second molars, maxillary tuberosity, the maxillary tuberosity, zygomatic buttress. You have to be always posterior to the zygomatic buttress. The buttress comes in the region of the first molar. Then we have to be posterior to the tuberosity, zygomatic buttress, anterior to the tuberosity in the region of the second molar tooth. Where is the point of insertion of the needle? Height of the mucobuccal fold in the region of the second molar. What is the angulation? You angulate the needle at 45 degrees to the vertical, horizontal and also directly medially. So, what is the precaution that we have to tell the patient? please keep the mouth partly closed. We keep the mouth partly closed. Can you see the central image? We keep the mouth partly closed so that we have adequate cheek space to take the needle medially directed by 45 degrees. So, where is the final position of the needle? The final position of the needle is in the pterygopalatine fossa. So, it is in the pterygopalatine fossa. Do we have a bony landmark? No, there is no bony landmark. We do not hit any bone in this area. The needle is in the soft tissue. You aspirate in two planes and then deposit the local anesthetic agent. So, what are the areas that are anesthetized? We know that we are blocking the complete maxillary nerve, the ganglion along with all its branches, which include the PSA, MSA, ASA, infraorbital, all its terminal branches, including zygomaticofacial and temporal. So, completely one half of the face is completely anesthetized. The mid-third of one half of the face is completely anesthetized when we give a maxillary nerve block. Again, what are the common complications that we can have? We can have hematoma, which is mainly caused because of injury to the pterygoid venous plexus. Rarely we can have the maxillary artery, which can be injured, because of which we can have hematoma again. Yeah. So that is high tuberosity approach or the maxillary nerve block that is happening through the buccal side. Now let us look at greater palatine approach to maxillary nerve block. Now, what do we know? We do know that the greater palatine nerve, which is a branch of maxillary nerve, is coming and traveling through the descending palatine canal and supplying the palatal mucoperiosteum. Yes. Now, where is this descending palatine canal? It is located between the perpendicular plate of palatine bone. What you are seeing, this blue bone that is present here is the perpendicular plate of palatine bone, and the pink bone that you are seeing here is the maxilla. So, at the junction of these two bones, the canal that is located is the descending palatine canal. Now, let us correlate from the lateral side. This is the pterygopalatine fossa. That blue bone you are seeing is the perpendicular plate of palatine bone. At the junction of these two, at the medial extremity of the pterygopalatine fossa is nothing but our descending palatine canal. So, if we can get our needle into the descending palatine canal and then reach the pterygopalatine fossa, we can again deposit a local anesthetic agent to anesthetize the maxillary nerve. Have we gotten that? So, we identify the greater palatine canal, pass the needle through the canal to reach the pterygopalatine fossa, and there we anesthetize the maxillary nerve. So, now let us look at the landmarks for the same. Now, we can see that is the greater palatine foramen. So, to rehash, how do we locate the greater palatine foramen? The first landmark we would see is the second molar tooth. The distal half of second molar tooth is the most important landmark. The next is the vertical alveolar shelf in the region of the second molar. Then the horizontal alveolar shelf in the region of the second molar. Once we have identified these three areas, then we pass our finger in this area and we will feel a small dip in the mucosa that will correspond to the greater palatine foramen. Now, we take the needle from the opposite side, inject into the landmark, into the dip that we had palpated with our finger. Once we feel the depression and then we palpate with our finger, we localize that area and then take the needle so that it enters that depression. From there, the needle is passed through the greater palatine canal. Once it passes through the greater palatine canal, that is when the tip of the needle can go straight into the canal and the tip of the needle will be lying in the pterygopalatine fossa. So, that is where we deposit our local anesthetic of 1.2 to 1.5 cc so that the maxillary nerve can be blocked. Now, what is the gauge of the needle you want to use in this technique? You can use a thinner gauge needle, that is a 27 gauge needle, and you can use a 25 millimeters needle or a long needle also. However, once you locate the canal, guide the needle through the canal to enter the pterygopalatine fossa. So, this is how we use a greater palatine approach to block the maxillary nerve. What are the areas anesthetized? As discussed earlier, the complete area of distribution of the maxillary nerve, which includes all the divisions of the maxillary nerve, are anesthetized by this block. So, complete maxillary branch supply gets anesthetized by the greater palatine approach to maxillary nerve block. What are the complications we can have in this technique of maxillary nerve block? It has a higher rate of needle breakage because we are trying to negotiate through the greater palatine canal. Second thing, it can again be extremely painful when we are trying to take the needle in. So, that is maxillary nerve block. The last one is, how can you block the maxillary nerve through an extraoral approach? We do know that the maxillary nerve is in the pterygopalatine fossa, and that is where it needs to be blocked. So, the first thing is we need to reach the pterygopalatine fossa. What are the landmarks to reach the pterygopalatine fossa? The first landmark is the zygomatic arch. We mark the midpoint of the zygomatic arch, which feels as a depression. So, you ask the patient to sit straight, you palpate the zygomatic arch and the glenoid fossa, mark the deepest point of the zygomatic arch. You can check that by asking the patient to open and close the mouth. You can also feel the sigmoid notch. What we are seeing is here, this curve between the notch present between the condyle and the coronoid is the sigmoid notch. So, the first landmark is the zygomatic arch and the deepest point in the center of the zygomatic arch, that is point 1. The point 2 is the sigmoid notch, which is present between the condylar and coronoid process of the mandible. The third landmark is the lateral pterygoid plate, which is present at a depth of 3 centimeters from the surface. That is the third landmark we have to reach. So, what needle do we use? We cannot use a short needle. We cannot not use a long needle, which is 40 millimeters, because if we insert the needle till the hub of the needle, the hub can break. So, that is the reason why we generally prefer using a spinal needle of same 25 or 27 gauge. Now, once you have palpated the landmarks, mark the midpoint of the zygomatic arch, mark the sigmoid notch. Now, take your needle, insert it through the skin at the center of the zygomatic arch. That is where you deposit 0.2 to 0.3 cc of local anesthetic, so that the patient does not have pain when you are advancing the needle into the tissues. Once you have infiltrated that area, use a spinal needle and then go deep up to a depth of 3 centimeters, that is 30 millimeters, wherein you will hit the lateral pterygoid plate. What do we hit? We will hit the lateral pterygoid plate. Once you have hit the lateral pterygoid plate, this is a bony landmark. You have to feel the bone in that area. What is the bone that you hit? That is the lateral pterygoid plate. Once you have hit that, now retract the needle from the tissues partly and direct it forwards. When you direct the needle forwards, you are between the posterior surface of the maxilla and the pterygoid plates, which is nothing but your pterygopalatine fossa. So, once you reach the pterygopalatine fossa, now you know what to do. We just have to deposit our local anesthetic in the pterygopalatine fossa, so that the whole of the maxillary nerve is bathed in the local anesthetic and the nerve is anesthetized. So, what are the landmarks again? Zygomatic arch, sigmoid notch, and then the lateral pterygoid plate. What is the depth? We have already discussed that. And how we reach? We retract the needle once we hit the lateral pterygoid plate slightly outwards. Don't pull it out completely. Just come out a little bit. Go in anterior-superior direction. Anterior-superior direction. Take your needle forwards. You will lose the bony landmark anywhere. There is your pterygopalatine fossa. Aspirate and inject. So, this is how we give an extraoral maxillary nerve block. To revise again, these are the landmarks that we are going to see. the deepest point of the zygomatic arch in the center, the midpoint and the deepest point of the zygomatic arch, then the sigmoid notch and the lateral pterygoid plate, 25 gauge spinal needle, point of insertion is the center of zygomatic arch, infiltrate some amount so that there is no pain when you are trying to advance a needle, depth of penetration is around 27 to 30 mm, and then we hit the lateral pterygoid plate, retract the needle and then go antero-superiorly so that we are in the pterygopalatine fossa, and that is where we deposit our local anesthetic. What are the areas that are anesthetized? The complete area that is supplied by the maxillary nerve, including the palatal mucoperiosteum, the nasopalatine, everything is just numb. Having done this, what are the complications that we can have? We can have hematoma because the area is extremely vascular and we can injure the pterygoid venous plexus. The second thing we can have is trismus, and sometimes the anesthetic may seep into the orbit through the inferior orbital fissure. That is when we can have ocular complications like diplopia. So this is how we achieve maxillary anesthesia, and the simplest of all is the infiltration. And how we give infiltration is we take the needle parallel to the long axis of tooth that we want to anesthetize in the mucobuccal fold, aspirate and deposit. So that is, these are all the techniques of maxillary anesthesia. Now, when do we choose what? When do we choose what? If we are working on a single tooth, let us say just a central incisor, then you can give infiltration, where you go just above the root of the central incisor, insert the needle into the mucobuccal fold parallel to the central incisor, aspirate and inject. That is, single tooth anesthesia you can achieve by infiltration. However, you are working on multiple teeth, you are working on multiple sides, the labial side, the buccal side, and also the alveolus needs to be blocked. That is when we need to choose a nerve block instead of an infiltration. That's all for today, and we will be seeing a video demonstration of all the blocks, including the middle superior alveolar and the infiltration in the video that's going to follow the lecture. Thanks a lot.